Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm also the vice chair of the BTOG steering committee.
And I'm Lianne, a respiratory physician at Barts Hospital in London.
This is part of our regular podcast series where we have informal chats with experts in their field and tackle the most important issues that we all face in the diagnosis and treatment of thoracic cancers.
It is important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content or delivery of anything discussed in these podcasts. We would love to hear your questions and comments on things we've discussed in this podcast. Please contact us by emailing us at info@btog.org or tweet us at btog.org.
So today's podcast is about thymic tumours, and we're going to be focusing on the non-surgical aspects mainly of thymic tumours, and absolutely delighted to be welcomed by BTOG friend and expert in all things thymic, David Gilligan. David is an oncologist at Cambridge University Hospital and also at the Royal Papworth Hospital, and is very involved in the thymic tumour interest group in the UK, and has held some excellent recent meetings about that. David, welcome to this podcast.
Thanks, Tom. Great to be here.
Now, I'm definitely not the expert here, being a lung oncologist, and when thymomas and similar such things come across the MDT, other people tend to be a bit more involved than me. So I'm going to ask my first question at Lianne. Lianne, you're the respiratory physician. You see these guys coming in. How do you tend to see thymic tumours appearing in the clinic? Is it different to how lung cancer patients present, for example?
So I think a lot of the patients that we see, the finding is often incidental. So we do a lot more CT scans now, kind of, I think, in general, in our inpatient population and also in outpatients. I work in quite a large trauma centre, so it's not unusual for a trauma patient to essentially be scanned from head to toe. And this is often the kind of thing, well, these kind of incidentalomas are the things we often find, mediastinal lesions, that then the patient's, got a fractured leg, and we're referred the patient on to investigate or start the workup. So I would say that probably a lot of, in my experience, a lot of the patients we pick up, it's often incidental when they're scanned for another reason. Some patients, I think, reach us through the kind of plain chest X-ray route, although most of the time thymomas or these kind of central mediastinal lesions aren't really seen on chest X-ray, and so it's usually cross-sectional imaging. Often they'll have other symptoms that are not really related at all, and they've had their scan, for another reason. Or even though they've got a persistent cough, it's usually pretty unlikely that the mediastinal lesion is the cause. So most of the patients we pick up and then investigate, I would say, are found incidentally. Obviously, there are larger lesions that may cause problems. So I don't know whether David would agree, and that's his feel from his patient population.
Yeah, I think most thymomas, I think we've got to remember, are early stage and will be picked up asymptomatically. Another route, I guess, which is small but not insignificant, is through associated conditions like, and the main one like myasthenia gravis, but also other rarer immunological or hematological conditions. There's a list as long as your arm of associated conditions, but myasthenia is way at the top of the list. So some patients with myasthenia will have thymomas, maybe up to about 30%, and some patients with thymomas will have myasthenia. And so there is another route in through neurologists and sometimes hematologists or immunologists, because there are these long list but of well-defined paraneoplastic or associated conditions.
Does that mean, because that's the one we all know about myasthenia and thymomas, does that mean that everyone with a thymoma should have a screen for myasthenia and good syndrome and the rest of them, or do you just do that if people are symptomatic?
I think it's becoming established as good practice to screen for these conditions, because it may be that that condition is the thing that affects their quality of life more than the thymoma itself. I don't think you need to go too far into extensive investigations. What I would say is a basic. I think most people will have a full blood count, so that would pick up any red cell problems, pure red cell aplasia, immunoglobulins to pick up Good syndrome, and an acetylcholine receptor antibody to pick up myasthenia. So when a patient is seen with a new diagnosis, I think that is the sort of baseline bloods that you should do, but I don't think you need to go any more if there are truly no other symptoms.
And what about the spectrum of the tumors themselves? So a whole different range of thymomas, all the way through to thymic carcinomas, which I guess what I would ironically probably see more of, can be confusing. What's the for me? What's the idiot's guide?
Well, I think people do get really freaked out about the pathology, because the one that's used most is the WHO classification, which has about 5 or 6 different categories. So it goes A, B, B1, B2, B3, and C. I would say that don't get too wrapped up in it. The rule is that C, which is sometimes not used, is thymic cancer, and that is a distinct entity from thymoma, and to some extent is managed a little bit differently, and isn't associated with these paraneoplastic or myasthenic type syndromes. So there is a rough association going sort of the A and the AB tend to be at the more inverted commas benign end of the spectrum. If you look at sort of maps of the stage versus the type, the earlier stage thymomas, the stage 1s, which are normally completely resected, tend to be more at the sort of AB, B1 type. And then the ones that you see with bulky disease, pleural metastasis, are more the sort of B2, B3 types. But really, in terms of managing the patient, you're looking more at the stage rather than the histological subtype. And as I say, people get terribly, well, they just sort of go a bit blank when people start talking about, the pathologist starts talking about these various histological subtypes. It's important, but it's not that important.
And when you're doing your investigations, what is your, is CT the one for us? Should we be doing MRIs? And when we have the eternal histology discussion, how are you recommending we do that to get tissue?
The basic investigation is CT, and the differential that we're looking for, I guess, is this benign? Is this a thymic cyst or thymic hyperplasia? And that can be quite difficult to define on CT, but MR, discussion with a thoracic radiologist about whether you need to do MR and what type of MR is quite important. I would say that the majority of early stage disease, stage 1 and stage 2, where the tumor is in the anterior mediastinum and the lesion is fairly well defined, most CTs and CT reports from radiologists will say that this is almost certainly a thymoma. And in that situation, if the MDT, it'll normally be a thoracic MDT or a lung cancer MDT, is agreed, then, and there's no evidence of any pleural disease or anything worrying about it, then it's well recognized that you can go straight to surgery without doing a biopsy, and we're not talking so much about surgical things, but you can have a pretty minimally invasive surgical procedure in terms of a thymectomy. If you've got something that looks much less well defined or is associated with symptoms or loss of fat plane, or indeed, as I said, pleural nodules, then we're probably more into the realm of getting a biopsy, which is usually a CT guided biopsy, because there are differentials. There are the main one being lymphoma, but sarcoma, germ cell tumors, metastasis, sometimes even lung cancer can come into the differential. So I say that there's really three categories. There's the completely benign, that you can say, this is not an issue, this is not a problem, and no one needs an operation, and you can be followed up for a bit or discharged. The ones that are clearly early stage thymomas, they can go straight to surgery without a biopsy, and the ones that are usually more extensive, or some got some sort of nasty features on the CT scan, and they would go to biopsy. And probably the role of PET scanning is probably something that needs to be discussed in those final group of patients, but I think generally speaking, not in the others.
Got you. Lianne, I've been very rude and dominated all the questions, so I'm going to shut up for a second and because I find it very interesting. So I'm going to be quiet and let you ask some questions.
No. I was just going to add that I think there's a group of patients that obviously oncologists don't see, that we still follow in respiratory, where MRI is often used. As David was mentioning, the kind of benign group, we use MRI to find whether there's a cyst or a thymoma, but try and differentiate with hyperplasia as well, because obviously there's a separate group of patients who, when we think perhaps they've just got hyperplasia, we might follow up with annual MRIs. That's our current local protocol.
And you're doing MRI
people,
to reduce radiation dose in this young patient group, or just because it's better defining the abnormality?
My understanding from my colleagues is that's is a much better way of defining what's going on, and that the group with the thymic hyperplasia we often will keep an eye on, as it were. But I think that David's quite right about it's very helpful to have David's opinion about the different imaging modalities. So you feel, David, that PET is really only useful for where there's concern about invasion or advanced disease?
I think there is a bit of a lack of consensus. One thing that we're doing in the the BTOG Thymic group is we're having a discussion about having an anterior mediastinal pathway, which we're actively discussing at the moment. It's in development, and I think that hopefully we'll be able to produce a document that people can refer to as to what imaging is needed in what situation, and obviously that's in conjunction with thoracic radiologists. So watch this space.
Excellent. We're going to slightly stay away from the intricacies of surgery. It's quite tempting to turn and talk about what do we do before surgery. We're going to skip that because we are hoping to have a surgical podcast on thymomas. But what I might ask you, David, is what's your view on neoadjuvant treatments? Now, these are coming into lung cancer quite a lot. Do they have a toehold in thymomas, or are we really, when we're thinking about treatments around surgery, are we confining ourselves to adjuvant treatments?
There is a role for neoadjuvant treatment. You could divide it into neoadjuvant chemotherapy and neoadjuvant chemoradiotherapy. I think the direction of travel is away from chemoradiotherapy, more towards chemotherapy, although the thing with thymomas is that we are quite often in an evidence-free zone, so we don't have large studies to fall back on, and certainly don't have a lot of trials to fall back on. But as far as neoadjuvant treatment is concerned, it's the stage 3 or stage 4A disease. So stage 3 is where you've got invasion around the pericardium, and the surgeon at the MDT feels it might be difficult to resect, or it's rather too bulky to resect. And also if there are pleural deposits that might be difficult to resect. So giving chemotherapy, and we can go into the sort of regimes that are used, but they're generally platinum based regimes, and you can get about a 50% response rate with chemotherapy. and that might make surgery easier. And the aim of any surgery, although maybe less so in the more advanced diseases, to get an R0 resection. So if you've got a more bulky or more invasive looking tumor, that's a thymoma, then that would be. With thymic cancer, it's quite often they are more invasive and aggressive, and it's more difficult. It's more difficult to get clearance. Many surgeons I've worked with have said that when they've been doing what they think might be quite big operations with patients with thymoma, the tissue planes are actually quite well preserved, and so the surgery can be not always, of course, but can be easier than they expected.
And David, is there a kind of standard chemotherapy regime that you can consider, or is that a bit up in the air?
I don't think it's moved on an awful lot in the last few years. I suppose there are three that are in general use. There is, for the oncologists listening, they're all platinum based. There's cisplatin etoposide, or cisplatin, doxorubicin, cyclophosphamide. They're more for thymomas, and carboplatin, paclitaxel, slight bias towards thymic carcinoma, but they can all be used interchangeably, I feel.
And in the adjuvant setting, we're much more guided by stage, histological subtype. What's your take on that? And I guess that slightly leads on to also the joys of thymic staging. Masaoka Koga, which always sounds great. TNM sounds much less good.
Yeah, I think we're all kind of getting used to and transitioning to TNM from Masaoka Koga. I can never say it.
Oh, that sounds much better than the way I did it.
And a lot of, up to some selected stage 3 Masaoka ones are still in the realms of PT1A tumors. So it is a bit confusing. I think the bottom line is whether something is R0 or not. And there has to be a good discussion between the pathologist and the surgeon as to what is R0 and what might not be R0. And that's key. I think the stage is less important. And when we're thinking about adjuvant treatment, we're thinking that it's more to do with, if it's R1, do we give radiotherapy or not? And you've got to take quite a number of different factors into consideration. There are various guidelines. The ESMO guidelines that exist are very good. They probably are a little bit more advocating adjuvant radiotherapy than most key people do in the UK. I think we are a little bit concerned about irradiating people who, given some of the thymoma patients might be in early middle age or younger, irradiating around the heart. And so one's got to take that into consideration, because you may be giving them undue cardiac toxicity, because you've got to look at the overall figures. If you look at 5 and 10-year survival of stage 1 and stage 2 thymomas, you're looking at something which is in the 90% plus bracket. And so I think there is a risk in treating thymomas of over-treatment. Thymic cancer, I think, is much more difficult to pin down, but I would perhaps not unexpectedly, you might go for more in the way of adjuvant treatment, even if you've got an R0 resection, just because it is a much more aggressive tumor. So there are various things to take into consideration, but one of the sort of the cardinal thing is, if you've got an R0 resection and you've got a thymoma, then I think you've got to think very long and very hard about whether you should do any adjuvant treatment at all, whether you need to give radiotherapy. And I think the direction of travel is moving towards not giving adjuvant radiotherapy unless there is clear R1 or R2 disease in thymoma, and in thymic carcinoma, again, you've got to weigh up all the risk factors.
And in those patients that do have an R1 or incomplete resection, is there any evidence for kind of higher doses or larger fields, or is that a bit old hat now?
I think the radiotherapy is probably just to the involved field, which actually can be quite difficult. And again, I talked about the surgeon and the pathologists coming together to try and work out what's going on. And if you've got an R1 tumor that you want to irradiate, the tumor bed, if you like, surgeons may, if they were concerned that they were going to do an less than R0 resection, they may put clips in to help. But I think it's obligatory to sit down at the MDT, or when you're doing your radiotherapy planning as a clinical oncologist, with the surgeon and the radiologist to define where you are wanting to irradiate. So I wouldn't do extended fields. I would just do involved fields around the tumor bed. But that can be difficult because you're sometimes looking at nothing. You're looking at a space between the heart and the sternum, which is now empty, which previously had a tumor in it.
And
after your, sorry, go for it.
I was just going to say, because we touched on the neoadjuvant treatment, but I don't know if you mentioned, is there any role in radiotherapy there, kind of pre-op, or is it more chemotherapy? If we,
well, yes, there have been studies looking at both. As I say, I think the evidence is light. Probably the direction of travel is more towards neoadjuvant chemotherapy rather than chemoradiotherapy. And if something is truly not resectable, then definitive chemoradiotherapy is certainly something that can be considered. So, but I think neoadjuvant radiotherapy as a sole modality is not really something that's recommended.
In fact, there's really good ESMO guidelines, aren't there? There's quite a good flow chart showing in whom you might want to consider which adjuvant and indeed neoadjuvant modality, and I find that quite useful.
I'd say that the ESMO guidelines that are produced, they're now more than 5 years old, but they are very good, and you can't go far wrong if you go and have a look at the ESMO guidelines. There are some new ones that have just come out that have been published in the they're an update published in the Journal of Thoracic Oncology by Ontario Cancer Care, a Canadian group, and we were looking at them in our Thymic group last meeting. It's not an easy read. But
unlike other guidelines,
well, just the way that they've updated them, and the formatting is just terrible. But buried in there is some some evidence based, and they've produced some they have trawled the data for the evidence. And what they've said is that they're because the ESMO ones are pre-TNM, they're based around Masoka Koga, but I think the ESMO, the ESMO guidelines are still pretty sound.
And follow up. Let's keep it before we move on to the advanced stage stuff. Follow up. They've had their surgery. They've had they may or may not have had some adjuvant treatment, but follow up's quite long term. Certainly for my patients, I'm doing CT or MRI scans, and ESMO guidelines, I believe, talk about a minimum of a 10-year follow-up. And I guess that reflects the potential for late recurrence, rather unlike other lung cancers where late recurrences tend to be a less common event.
Yeah. It's, again, I think you've got to just take a step back and look at and be realistic. And I'm not sure, and I think it would be a very good project in the UK to see, and I know that there has been trainee group that's looked at different practices, and people vary between 5 and 10 years, but you're right, the ESMO guidelines do say 10 years. What I think is standard is that 3, usually post-op, at least 3 months to let the sort of smoke of surgery settle, do a baseline CT, and you'll normally see a bit of thickening or residual change, which is your baseline. And if you've got an R-naught resection, you know that that's just post-operative change. And then if it's an R-naught resection, the ESMO guidelines, I think, say do an annual CT scan for 10 years, which is fair enough. Except, I suppose, if you've got a young patient and you don't want to expose them to radiation, then MR is a real alternative. You've got to probably discuss it with your radiologist, but it is a real alternative. So yeah, I think follow-up is, again, something we, given that stage 1 tumors will be very, very curable, again, we may have to look and see actually how many late recurrences are we picking up in these tumors with good surgical technique, and I think that there is room for a little bit of little bit of research into whether we do need to follow these up so intensively.
And as a respiratory physician, I tend not to see these patients post-op. We either we make our surgeons follow up our thymoma resections, or obviously they go to oncology if they need any adjuvant treatment. So just out of interest, in these patients that have a long-term follow-up, where do you see the recurrence? Is it usually the tumor kind of resection site, or do they get distant kind of pleural-based recurrences? Just in your experience, yeah.
In my experience, with stage 1 and stage 2 disease, I'm seeing hardly any recurrences, whether they've had adjuvant treatment or not. They would tend to be local, but the other big area that you've got to look out for is sort of so-called drop metastasis in the pleura. So thymomas, distinct from thymic carcinomas, don't tend to metastasize very widely outside the thorax, but anything is possible. Whereas thymic cancers behave in a much more aggressive, pattern of spread with, liver metastasis or bone metastasis or whatever. One thing that you do have to look out for sometimes in patients with advanced stage 4 disease is that you get metastasis. I've seen it in a few cases of going down right into the costophrenic angle and going around the liver, which is quite challenging to manage.
And thinking about the metastatic disease, you mentioned earlier a couple of regimens. Are those the same chemo regimens we're thinking about in the advanced stage as well? So yeah, etoposide, cis, cap, cyclophosphamide, dox and cis, and carbotaxol more for thymic carcinomas. Does that hold roughly true?
Yeah, pretty much. And all of those regimes are used in the advanced setting as well as the.
Do you have a personal favorite? What's the Gilligan technique, or do you sort of put your hand in the air and just guess one?
Well, I'm moving more towards carboplatin paclitaxel because it's easier to give and seems to be better tolerated. I used to use a lot of cap, but I'm moving away because it really is quite a nasty, toxic regime with 3 very nasty drugs in it. But
it is a challenge, and your cardiologist doesn't thank you for it either.
Exactly.
And what about immunotherapy? Obviously, hugely important in most other lung cancers. A bit more challenging in thymic tumors. Not licensed, we should add. Do you see it having a role? What's its evidence? Do you ever use it if there's funding available for it?
I think its role is certainly not yet defined. The concern in the trials that have been done to a greater or lesser extent is that there does seem to be a much higher rate of immunotoxicity, particularly with those thymic tumors rather than thymic cancers. And so the most of the work that's being done or has been done is more on the thymic cancers rather than the thymomas. There is a trial at the moment, which is it's either EORTC or ETOP or both, I can't remember, the Nivothyme trial, which is a phase 2 study, which was originally giving nivolumab after first-line treatment for those who had thymic cancer or the worst thymoma, the B3s. That did show some response, but it didn't meet its endpoint, and it's been rejigged to include nivolumab and ipilimumab. And so there are a couple of centres in the UK taking part, the Christie and the Marsden. So we wait and see whether that's a viable regime and a safe regime. I think there is concern that you may be getting much more immunological toxicity than you do for other tumor types with immunotherapy. There are lots of other regimes, that chemotherapy regimes that have been used. There's gemcitabine and gemcitabine and capecitabine, single agent pemetrexed. There's a whole lot of phase 2 studies which show variable degrees of response, usually in the second line setting. And in terms of targeted therapies, there's things like more for thymic cancer again than thymoma, there's sunitinib. But the evidence is more towards stable disease rather than, fantastic responses in subsequent lines of treatment.
And again, we should probably say that those remain unlicensed, I guess, reflecting the rarity of the tumor.
Yeah, I mean, that's the problem, there really isn't anything that is truly licensed for these tumors because they are so rare.
And prognosis, I mean, you touched on thymomas may come back late. We know thymic carcinomas in the metastatic setting more aggressive. Can you hazard a prognosis, or is it just so variable as to be impossible to say?
No, I mean, I think what we have to realize, if most of us are treating lung cancer as our number one tumor site, and thymomas come in as a bit of a, an added extra, that the prognosis and the natural history of these is much slower and much better than lung cancer. So even for, say, stage 4 disease in thymoma, you're looking at certainly 5-year survival rates of 50% and even approaching 40-50% at 10-year survival. So the prognosis is significantly different in these patients, and quite a lot of them, particularly, you do see people who have got advanced disease with quite a bulk of disease in the mediastinum, and you look at the CT scan and you think, oh my God, that's going to be an absolute wreck of someone and they walk into and they're actually look really very well. And so what it is about the biology, I don't know. It could be that they're very slow growing and they tend to sort of grow around things. That there are people walking around with massive bulk of disease who you just, jaw-dropping amounts of disease, and actually they're quite well. And you've got to remember that, you have to sort of just pause and think, what's the best thing to do in a particular patient? And some of the treatment might be sort of observing people until you think that they might be about to develop symptoms, and then come in and try and treat them at that stage. Sorry, I've forgotten your question.
that was my question. I think we're pretty much up to our allocated time. Lianne, anything else you wanted to pick David's brains about whilst he was sitting in front of us, so to speak?
I guess from your point of view, what do you think the kind of future holds in terms of the treatments? Do you think targeted therapies and immunotherapy are kind of going to become more of the mainstay, or is this such a niche kind of illness at the moment that we're kind of going to be sticking to our current kind of treatments?
I think that's a really good point, and I don't know. I mean, the problem is that with rare tumors, you get very little in the way of evidence, and again, as we've talked about a lot of unlicensed treatments, and so anything is going to be a bit sort of almost anecdotal. And I think progress is slow. But if and there may be some movement in, lots of rare tumor types getting together to sort of lobby pharma and other people to do trials or to do studies or to do licensing. I mean, I don't really know what the easy answer is, but basically enabling new treatments to be used, or orphan treatments, I guess, that might be a way forward. But I think another way forward is trying to educate both patients with thymoma and healthcare professionals about the fact that you're dealing with a disease that fits much more with the paradigm of a chronic disease that you live with in the more advanced setting. But actually, as we've said a number of times, in the early stage, you're curing these people with an operation, and they are cured. And a number of patients of mine have asked me with thymoma, they say, well, if you can't cure it in a more advanced stage disease, what are you going to die of? And actually, not that many people die of thymoma. They sometimes die of the other associated conditions. They die of myasthenic crisis. They might die of hematological disorders like pure red cell aplasia that are actually a more serious sort of counterpart of this.
I'm going to call it an end of a night there. David, thank you so much. Tour de force. What I would strongly recommend anyone listening to this is that you go onto the BTOG website. Become a member, first of all, then go on to the BTOG website. And the entire thymoma study day is available on there. And I watched it about 3 weeks ago, and it's excellent. And it's truly multidisciplinary, and you can learn a huge amount. And the very next week, a patient came in with thymoma. So I was full of interesting facts. And you can find that at btog.org. So thank you very much to David Gilligan for joining us and sharing his thoughts. We hope to have another podcast on the surgery of thymomas, and that will be coming up shortly. So thank you very much, David. Lianne, thank you very much again for helping out, and we very much hope people will join us for our next podcast, which will be out in about 4 weeks' time. Thank you.
Thank you, Tom. Thank you, Lianne.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed. And for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.